Chris Patrick. I'm a registered nurse. I'm also a dementia capable care specialist and a certified instructor and a master trainer in dementia reality. We're going to talk about dementia, depression, and delirium today because sometimes they present separately and sometimes they present all at once. So sometimes it's nice to know what the difference is between them. So we're going to talk about dementia, the types and outcomes, symptoms and causes of depression, symptoms and causes of delirium, assessment, diagnosis of dementia, depression, and delirium, and then therapeutic and medical approaches to all three. And then as caregivers, our approaches to any one of those three. So what is the word dementia? The word dementia is derived from the Latin word meaning crazy or insane. Isn't that nuts? And no pun intended. I just think that they didn't know what it was back then. The problem is with that term, and everybody keeps using it, they all are getting the same connotation from that. That is why in our medical guide for psychiatric and cognitive disorders, they have changed the word dementia in the diagnosis, and they call it neuropsychological degeneration or changes, neurocognitive changes, which really just says that there's changes in the brain and there's nothing in there about being mad or insane or crazy. And that's how people used to see it, unfortunately, but we know better now. And mild cognitive disorder is what we call evidence of modest cognitive decline from a previous level of performance. So where you are performing today, if you slide a little bit, you're going to have mild cognitive changes. If it stays that way, then you would have a mild cognitive disorder. You look at that in one or more cognitive domains based on concerns of a knowledge informant. So based on maybe your family member that reports this or goes to the doctor with you and talks about some of those changes. And those changes are going to be in sense and smell, in what do I want to say? Sense of smell and executive function and cognition, maybe in movement. So there's a lot of different things that come into play with mild cognitive disorders. The major cognitive disorder then, which is kind of a step up from that mild cognitive disorder, is our major cognitive disorder, and that is evidence of a significant cognitive decline from a previous level of performance in one or more. And that's really the key word. You have to have one or more cognitive domains that have changed and are based on your concerns. So, that's what we're talking about when we talk about dementia. Keep in mind, dementia is not a specific disease. It's really a descriptive or an umbrella term for a collection of symptoms that can be caused by several disorders that affect the brain. People with dementia have significantly impaired intellectual functioning that interferes with normal activities and relationships. They also lose their ability to solve problems, maintain their emotional control, and they also may have some personality and behavioral changes. We may see agitation, we may see delusions, and we may see hallucinations. While memory loss is a common symptom of dementia, memory loss by itself does not mean that a person has dementia. Doctors diagnose dementia only if two or more brain functions, such as memory or language skills or executive function, are significantly impaired without loss of consciousness. What they're saying is if you hit your head and you have some deficits, it's probably caused by brain injury. if you haven't hit your head, you haven't lost consciousness, and you're having some of these loss in these cognitive domains, then we can look at dementia. However, keep in mind, there's a lot of diseases that may be neurocognitive changes, but may not be dementia. It may not be Alzheimer's disease or the other dementias out there. An example of that is ALS or Huntington's. Both of those don't start out with cognitive disorders. Those are more movement disorders, and it may move to cognitive disorders later on in that arena. Now, the other thing I want to tell you is there are some things that can change a person's cognitive level, but we look at those, and this is what's going to happen when someone goes to the doctor. We are going to look at what's going on with that person, both mentally, cognitively, and we're also looking physically. And there are some things that happen to older adults physically that will change your cognition: urinary tract infections, upper respiratory infections, dehydration, metabolic disorders, thyroid disorders. So typically when someone is going for an evaluation, because we're seeing changes and maybe they happen very quickly, we're going to do a boatload of tests on that person. We're going to do a urine. We're going to look at their lungs. We're going to look at their metabolic profile. We're going to look at their blood sugar because maybe they are now diabetic. So if it's not a cognitive disorder, a neurocognitive disorder, and we see that the labs are off, then we know what's going on with that person. And here's the key: once we fix that, we will see a change back to their normal cognitive place, if that makes sense to everyone. So you fix it. You fix the urinary tract infection. You fix the metabolic disorder. You hydrate them, and they're no longer going to seem confused. And it may take a day or two for them to get out of it, but you will see those changes. Typically, with a urinary tract infection, once you put them on antibiotics within 24 hours, typically 24 to 48 hours, you're going to see a change back to close to their normal cognition. All right, so dementia is a range of neurodegenerative diseases and conditions that cause progressive cognitive and behavioral impairments affecting someone's. And for the people that don't know what ADLs are, that's activity of daily living. ADLs are activities of daily living. And your activities of daily living are going to be anything that you need to keep yourself healthy and clean. So it's cooking, it is eating, it is bathing, it's brushing your teeth, it's combing your hair, it's being able to walk, button your own shirt. Those are your activities of daily living. The instrumental or independent, there's two ways to say that, activities of daily living, or your IADLs, are the things that keep you moving forward every day and keep you living independently, cleaning your own house, going grocery shopping, taking care of your bills, cooking for yourself. Those are IADLs. The ADLs really show you that someone has changed if they can't perform those duties anymore. We also know that dementia itself is chronic and persistent. It has no known cure. We're getting close to figuring things out. We are so close. And within the next couple of years, you should be hearing about some pretty significant changes in the arena of Alzheimer's disease itself. It can be caused by damage to the brain. It almost always is caused by pathological changes to the brain. Things like plaques and tangles, Lewy body, Pick's disease, those all have significant pathologies in the brain. We talked about some of those symptoms being caused by reversible conditions, and for dementia, the true diagnosis of dementia, it's going to be irreversible. And then types of dementia and symptoms are really based on which region of the brain is damaged, but also what the pathologies are. For example, Alzheimer's disease, the pathology that we see in the brain are plaques and tangles. The pathologies that we see in the brain for Lewy body disease are Lewy bodies. So that's how we can kind of distinguish. And really, both of those diseases I just mentioned really start in different parts of the brain. What we do know about dementia, and I want you to keep in mind, it is not a normal part of aging. 100 years ago, we thought it was, and even less than 100 years ago, we thought it was. I can remember I had a grandmother who probably had dementia, but they were like, oh, she's just old, she's aged. And so what we know now is that is not a normal part of aging. And in fact, there are quite a few older adults who are, 100%. A friend of mine's mom will turn 100 this year, and she's just starting, not even in the depths of it, just starting to be forgetful. Her biggest problem is movement. She has a lot of arthritis. So, her issue is going to be getting around independently. So she is confined to a wheelchair when she's going distances and to a walker when she's just walking around her apartment. And she's still living independently in her assisted living. And I know that sounds kind of contrary, but excuse me, she's able to do almost everything herself. She just moved to assisted living because of her movement issues and because she was falling a lot. So that gives you an example of the degree of how people can age. This is that umbrella term that we always talk about with dementia. What it has in the red part, the top part of the umbrella, the three that you see up there: Alzheimer's disease, frontotemporal dementia, and vascular disease. Those are probably the three top dementias that you will see. Right below it is dementia with Lewy bodies, and I'm going to tell you that it's very close, almost percentage-wise, with frontotemporal dementia. Now, below that, you're going to see just a few, but I will tell you it depends on who you talk to. There's going to be anywhere between 50 to 100 different types of dementia. I'm not saying there is 50 to 100 types of neurocognitive disorders, but some people say it's that high. All right, so let's get into Alzheimer's disease. Alzheimer's disease causes brain changes that gradually get worse. In Alzheimer's disease, brain cells degenerate and die, causing a steady decline in memory and mental function. So, and if we were going to get into depths of Alzheimer's disease, I would tell you that there's stages. And there's early, there's mid-stage, there's late to end stage. So if you're in early stage, you're going to see a little bit of decline. And then as the disease progresses, you're going to see in middle stage, you'll see maybe that's when behaviors start to, arrive, and you might lose some of your more cognitive ability, like maybe dressing yourself, things like that, until you're confined to bed, late end stage, and you're unable to communicate. What is in the brain, like I said, are plaques and tangles. Those are the differentiating component of Alzheimer's disease. And the progress of the disease is a steady decline. It starts at the top, and little by little, it goes to the end point. Alzheimer's disease is a life-taking disease. It typically lasts about 10 years, give or take. And because every brain's a little bit different, because we're all very unique human beings, everyone's journey in Alzheimer's disease is going to be a little bit different. I will tell you from my personal experience, my mom had Alzheimer's, and many families do this, and yet I train Alzheimer's, but when it's that close to you, you look at it a little differently. We were probably supporting my mom independently in her home for about 2 years, doing some of her grocery shopping, cleaning her house. So she had mild cognitive impairment at that point. And we were, with support, were able to keep her in her house. And then it moved to Alzheimer's. We saw that she was starting to have more cognitive failures. So her journey with Alzheimer's disease itself was 10 years. Mild cognitive impairment was about 2 years. 1 in 9 people who have Alzheimer's disease, 1 in 9 people who have mild cognitive impairment will move on to have Alzheimer's disease. This is just a picture of our brain. And what you're seeing here is the cerebral cortex. That's kind of the jiggly stuff, that's wiggly stuff that's out here. And in here is the hippocampus. And the hippocampus is where we form new memories. Up here in the cerebral cortex, that's where we're responsible for language information processing. So, and I will tell you that the different lobes of the brain do different things for us. There's a part of the brain that is involved in thinking and planning, and the ventricles keep the brain healthy. And then the hippocampus, like I said, is memory and emotions. You can see the difference between a healthy brain, and you can see the difference between a brain that has dementia. You're going to see that the ventricles are a little bit smaller, and the ventricles are filled with more fluid. And you see that the hippocampus, you can barely see it down here, but it shrinks quite a bit. Now, this is where I'm going to get on my soapbox. And I'm going to tell you something that's not related to dementia, but it's related to every adult, is that our brain normally shrinks a little bit when we age. Your brain is about 3 pounds. You'll lose about a half a pound to a pound of your brain as we age, and you'll lose probably a pound to maybe a pound and a half when you have dementia. What does that mean for us who are normal, older adults? I want you to take a look at the ventricles in this brain and the ventricles in this brain. Now, keep in mind, this is a brain with dementia, but also the space around your skull. This is pretty much almost flush. There's room for a little bit of fluid there, but it's flush, closer, I would say, not flush, against the skull. There's going to be a lot more room here because our brain is shrinking as we age. What does that really mean for us as older adults? If this person whose brain is of the normal size trips and falls and hits their head, and they have what we call a brain bleed, they're going to know within an hour of two that there is something going on. If you can think about the actress, and I don't remember her name right now, she was skiing, she hit a tree, she was married to Liam Neeson. And within an hour to 2 hours, she was unconscious, and she was at that point of no return, and they could not save her. This brain, because there's more room for fluid, is going to take longer. And so you're not going to see that brain bleed until it's catastrophic, if you don't go to the hospital when you hit your head. And that's why I'm telling you, as older adults, if you hit your head, but you feel quote unquote fine, you still need to go to the emergency room, and you need to have them evaluate you, do a CAT scan or an MRI, whatever they choose to do, and do what's called a neuro check on you. They look at your eyes, they have you do balance, they touch your nose. Can't do those things at home, because that can save your life, because this is going to take maybe a couple of days. And in that couple of days, there'll be so much bleeding and pressure in your brain that then will be too late. If you catch it early, there's a lot they can do to make sure that you return to a healthy status. So I'll get off my soapbox, but if you ever hit your head, even though you don't feel like you hurt yourself, you need to seek help. Okay, on to a vascular dementia caused by blockage to the brain's vascular system. And those are caused by strokes, trans ischemia accidents, TIAs, or what we call mini strokes. vascular disease to small blood vessels in the brain. If you have problems with your blood vessels or, in your body, if you have cardiovascular disease, there's a good chance that you're going to have changes in your blood vessels in your brain as well. Anything that causes infection in your body is going to cause, anything that causes inflammation in your body and infection, but anything that causes inflammation in your body is going to cause inflammation in your brain. And that is also going to cause restriction in those blood vessels. As far as the progression, it's going to vary by person to person and what kind of vascular risk factors you had before it. Impairment also will progress with each additional stroke or vascular accident. Your chances after you've had a stroke of having another stroke within the first year is about 50%. And usually if that first one wasn't not catastrophic, I can't talk today, I apologize. If it was not catastrophic, it's going to be catastrophic in your next stroke or the stroke after that. Therefore, vascular dementia is really what we call a stair-step dementia. So you originally have the stroke, or you have some insult in your brain, lack of blood flow, and then you stabilize for a while, and then you have another maybe mini stroke, or your vascular disease gets worse, or you have another stroke and you decline again, and you stabilize there for a while, and then you have another stroke and decline. So that's why we call it the dementia that is stair-step. The lifespan of people with vascular dementia after diagnosis is 3 to 5 years after their symptoms begin. And again, there's a lot of variation on this. I had an aunt that I was the caregiver. She'll be gone a year in September, but the previous September, she had her first stroke, and then she had her second stroke a year later. And so that was 2 years after her initial diagnosis. So again, it depends on the variation in who those people are and what kind of damage they may have. Symptoms of vascular dementia could be poor judgment, memory loss, hallucinations, inappropriate behavior, misplacing things, difficulty organizing, a decrease in language skills, and some personality changes. And I am going to tell you that you may not have all of these. You may have 2 of them, you may have 3 of them. You may have some and they may go away and or get stable, and then you have another incident and you will see more of the same. And it'll be more difficult for that person to handle. Our next one is Lewy body dementia and Parkinson's disease dementia. We kind of put those together because Parkinson's disease can exist by itself and Lewy body can exist by itself. But really, Lewy body dementia covers 2 related conditions, and those are the 2 that it does. The defining features of Lewy body dementia include those Parkinsonian motor movements and a change in cognition. It's all related to the timing of the dementia onset that distinguishes it between Parkinson's disease dementia and Lewy body dementia. That diagnosis of Lewy body dementia is very challenging, and even on in the people who are experts in this, they may find it a problem to diagnosis. Because a lot of those, Parkinson's disease and Lewy body dementia, have the same genetic similarities. However, what we're going to see is the difference in phenotypes and those clinical implications. Also, the location in your brain of the Lewy bodies also influences how that disease is going to manifest itself. So again, just remember, Lewy body can present by itself. Parkinson's disease can present by itself, but they can present together. And usually you have Lewy body disease dementia, the Parkinson's disease will come first, and then within about a year or 2, you'll start to see the change in cognition. So you're going to see changes in thinking and reasoning, confusion and alertness, changes in gait and balance. They're going to have well-formed visualizations. We're going to talk about hallucinations. I'm sorry. We're going to talk about hallucinations in a bit. And from a caregiver perspective, I want to talk about that, as well as delusions, sleep disturbances. And because it's affecting the visual interpretation part of the brain, because there's a space in that brain for everything that we do, they may see some visual, have trouble interpreting visual things, visual information. Unfortunately, there's no medical test that can diagnose Lewy body dementia. It's done on postmortem when they see where those Lewy body plaques are. It's really based on their history, their physical and psychological exam. And then we'll look at their blood test and brain scan to exclude. They have to rule out other things. And so for many people, it's really going to be that probable diagnosis, just based on what we're looking at. So our next one is frontal temporal dementia, or frontal temporal. They say it both ways. It doesn't make a difference. That usually affects people under 60 years of age. It is the second most common cause of early onset dementia after Alzheimer's disease. 60% diagnosed with frontal temporal dementia are between 45 and 64. And it's estimated in every 15 to 22, we're going to see that prevalence of 10,000 people. So we look at the general statistics for Americans, and that's usually 50 to 60 Americans are affected annually. So it's also known as frontal temporal disorder, frontal temporal dementia, or frontal temporal lobar degeneration. It is a group of diseases that have overlapping symptoms, but different causes in the genes and differing underlying pathologies. Usually it progresses rapidly, and it's associated in the frontal and the temporal lobes of the brain. And imaging studies may show progressive evidence of what we call tau or PIC bodies. So that's kind of the pathology that we see. And unfortunately, we're not going to see that until we see it on postmortem. So there's 3 distinctive clinical syndromes with the pathology. It really depends on what you're exhibiting as to how that's diagnosed. You're going to see in one a behavioral trait, and that's the most common type, is a change in behavior. Then you see the language, primary progressive aphasia. That's what Bruce Willis has. He has frontal temporal dementia. He started out, he was unable to really read and be able to interpret those words. So they were reading his script in his ear with a earbud, and he did that for a while. They still didn't know what was wrong with him. And then obviously it progressed where he doesn't have much speech anymore, if any. And then the other one is a motor decline, and that's ALS, or another one is what we call supranuclear palsy. That's not the same as ALS, but it is another movement disorder. So these are 3 of the movement disorders that are common in the progressive. So there's progressive motor decline, progressive language decline, and progressive behavior and personality decline. So I'm not going to get much into this slide. This really just talks more about the variance on it. What you will see, though, if you look down to the 4th bullet point, you'll see that with the progressive motor decline, it can involve movement problems that are slow movement, muscle rigidity. So it almost has that Parkinsonian gait, body stiffness, and changes in behavior and language. And so oftentimes, because they have problems with movement, they are really at very high risk for falling. That's why many of them go into assisted living a little bit earlier than maybe some of the other dementias, because they're falling all the time. And so you want to prevent those falls, because those can be life-threatening. Again, this is just a repetition of the slide that we just saw, but know that there's I want to talk about the second one. There's characterized by disinhibition, apathy, and stereotypic behaviors. They become less empathetic, and they may display some sexual behavior. They may be shoplifting. And so this is someone who never would have done that, and all of a sudden you're starting to see those behaviors. You might want to think that maybe this is what is happening to that person. And because of these changes in their personality, we're going to see a lot of depression in these people. The one key to this, and this is one of the key things that helps the professional diagnose this, because it's very difficult to diagnose, is that in those early stages, when they're having maybe the apathy, or they're not empathetic, or they have this euphoria they never had before, this disinhibition, we're not going to see any memory impairment. We don't see memory impairment in this stage until later. Also, I want to talk about the binge eating habitats. There are some people that actually, if they're keeping that person home with them, actually have to lock their cabinets and their refrigerator, because they will overeat and they tend to gain a lot of weight. We've talked a lot about, these plaques and tangles in our brain, and they really affect something called our neurotransmission. And one of the things that it does affect is how we get depressed. And so this is our little introduction to depression.
Depression is one of the most common psychiatric disorders. Symptoms of depression are often subtle and unrecognized by both patients and physician. The brain contains a network of interconnected nerve cells called neurons. The junction between the neurons is called the synaptic junction. The transmission of impulses from one neuron to another is facilitated by chemicals called neurotransmitters. The impulse triggers the release of neurotransmitters from one neuron, which cross the synaptic junction and attach themselves to the receptors in the adjacent neuron, sending the message through. Later, the neurotransmitter returns to the initial neuron via the reuptake channel. One of the causes of depression is believed to be the depletion of the amine neurotransmitters serotonin and norepinephrine. Antidepressant drugs increase the availability of neurotransmitters at the synaptic junction by blocking the reuptake channel.
So the reason I like to show this is because we talk about plaques and tangles, and we talk about in Pick's disease and changes in the neurons, and that is why, as you can see here, if we look at the neuron and the synaptic junction, you can see why people with dementia have a high risk of depression, because there's plaques and tangles there. There may be Pick things, disease there. So there's a lot going on. The neuron helps us do a lot of things. And one of the things it does is it releases those happier, like norepinephrine. So that's when we look at depression and dementia, that's why there may be a cause to that. So let's talk a little bit about depression in itself without having a dementia with it. There's something called major depressive disorder, and that's really just depression. And that's more than feeling sad or going through a rough patch for a day or two. It is a serious medical condition, and it requires a lot of understanding and a lot of medical care. And because it's not supported outside our mental health community, it really has a bad rap. And we know that there's a lot of people that live with undiagnosed depression because they feel the stigma of having that disease will misrepresent them. We also know that anybody can have depression. It doesn't make a difference what their age is, what their race is, what their ethnic, their social economic backgrounds. We all get depressed at some time, and some people get depressed for a longer period of time, and that's called major depressive disorder. It's not a normal part of aging like dementia is not, and left untreated, depression can be devastating for those who have it and their families because they have difficulty handling it. Because again, it's not seen as an illness. You know, I can say I have diabetes and people will say, oh, I'm sorry to hear that. And someone will say, I have depression. And some people will say, well, what are you so sad about? You have a home, a family, and so on. They don't really understand that's a chemical change in the brain. The symptoms are ones that you already know probably. It changes how we think, how we may behave, and how we function every day. We may feel sad or irritable or anxious. And I will tell you, anxiety oftentimes goes hand in hand with depression. Not always, but often. With depression, there's a lack of interest in hobbies and activities they once enjoyed, including sexual activity. There's going to be sleep problems. They're either going to sleep way too much or they're not sleeping at all. And they'll also have a change in their appetite. Some people gain weight when they're depressed, and other people will lose weight when they're depressed. So again, because our brains all are unique, we're going to have the same disease, but we're going to see it and handle it and feel it differently. But we may have trouble concentrating, remembering details. We may have difficulty making decisions. You may feel fatigued. There's a lack of energy and feeling listless. You may feel empty or hopeless, guilty or worthless, and that's why many people move from depression to suicide. You may see them doing less, or they may be bouncing around a lot because they're showing some agitation. With our older adults with dementia, when we're talking about behaviors, and I'm kind of going off beat here for a minute, but one of those signs in an older adult with dementia that they may have depression is those physical aches and pains, complaining of frequent headaches or cramps or digestive problems. And they've been evaluated and they don't have any clear cause for those. It may be depression. And then obviously when you have thoughts or suicide attempts. Now, we know that there are some reasons and some chronic diseases why people may have depression, excuse me, and that might be cancer, coronary heart disease, diabetes, epilepsy, MS, stroke, Alzheimer's disease, HIV/AIDS, Parkinson's disease, and rheumatoid arthritis. And I think for any of us out there, we can look at those and say, yeah, I can understand why that may happen. Because if you look at any of those, they may cause a drastic change in your life, whether it's movement or you're knowing that it might be, your illness is catastrophic like cancer, or you might be in chronic pain, and chronic pain itself can cause depression. There are medications that can cause depression as well because they change the chemicals in your brain. Chemotherapy, antibiotics, blood pressure medications, birth control pills, and there are some of the weight loss medications that can cause changes in your brain. That's one of the things that they do is they change that brain so you're not hungry or wanting food all the time. But it may also cause some depression. So if you're on a GLP-2 and you find that you're more moody or agitated, you may want to make sure you mention that to your doctor. So what's our treatment for dementia? I'm sorry, depression. And unfortunately, if you have insurance or you have Medicare, these treatments will be available to you. I'm not so sure that they're going to be available to you if you're Medicaid or you don't have insurance. But medications, counseling, exercise, good nutrition, and alternative therapies like music, massage, meditation, which are also your mind, body, and spirit approaches, and social support groups. Really, counseling should be first. Find out why you're depressed. Is it changes in your life? And then medication after that should be your next course of action. While you're doing all these other things at the same time, social supports, doing massage therapy or doing meditation, those are all things that we really should think about doing every day anyways, because it helps us release those endorphins. This is what TMS therapy or NeuroStar. This is something that's not new, but it's been in the last 20 to 25 years that has been very helpful for depression.
Several different areas of the brain regulate mood. Neuroimaging studies of healthy and depressed patients have shown different patterns of metabolic activity of these different regions. The brain regions involved in mood regulation are connected through neuronal pathways. These neuronal circuits communicate by releasing neurotransmitters. When there is an appropriate amount of neurotransmitters within these pathways, communication between brain regions is optimal and the mood circuit functions normally. However, in depressed patients, neurotransmitters become depleted or dysfunctional, and communication between mood regions is disrupted. Increasing the amount of neurotransmitters is an established approach to treating depression. Neurons and their release of neurotransmitters can be affected either chemically or electrically. Traditionally, drugs have been used to chemically increase the amount of neurotransmitters. However, because antidepressant medications are systemic, they elicit undesirable effects in the brain and throughout the body. NeuroStar TMS takes a different approach, exploiting the fact that neurons are electrochemical cells. It uses a targeted electromagnet to produce a pattern of pulsed magnetic fields. This electric current is powerful enough to elicit an action potential in neurons, causing the release of more neurotransmitters at the synapse. In addition to these local effects, NeuroStar TMS activates deeper brain regions that lie outside the direct action of the pulsed magnetic fields. Energizing these deeper brain regions causes secondary activation of brainstem neurotransmitter centers, which stimulates other brain regions involved in mood regulation. NeuroStar TMS therapy offers a unique mechanism of action by directly depolarizing local neurons, which modulates connected deeper brain regions. This allows NeuroStar TMS therapy to affect both local and deep neural circuits, all without causing unwanted systemic side effects.
So there's variations on treatment for depression, and that's one of them. This is also used for anxiety. And I will tell you, my son's a firefighter paramedic, and they had a very, very bad call. And he started with some anxiety after that, and he sought help. And this is what they did. So they put these electrodes on your head, and what you do is you watch something that is soothing, relaxing, and you just concentrate on that, and they look at the different parts of the brain and they stimulate those neurotransmitters. And it took about 6 months of going once a week for these to help, and not on any medication. So it is a new way to look at things, and more and more psychiatrists and psychologists are starting to do this. So we can see depression with dementia. It is, we know that depression is a treatable mental health illness. We also know that depression is not a normal part of aging. We do know that symptoms are frequently unrecognizable and assumed to be a part of the other condition that you may have, which is dementia, heart disease, or cancer. It's also confused with grief and loss, which are normal life changes. And again, because there's such a stigma, and we don't want to air our dirty laundry, people don't seek treatment. depression and dementia are often undiagnosed. It occurs in all types of dementia, and it can be a serious risk. It can cause that dementia to get worse sooner. So they should have their depression treated. And like I said, in a community setting like assisted living, we always teach our staff that if they're complaining and things have been checked out and everything is fine with what they think ails them, we may have to think that it might be depression. So here's the difference between depression and dementia. Dementia is often diagnosed when the problem may be depression and not dementia. The opposite is also true. Sometimes a person can be diagnosed with depression when they have dementia. You can be diagnosed with both depression and dementia and other illnesses all at the same time. So what we're saying here is they can exist independently, they can exist together, and you can be diagnosed with them separately or together, even with other illnesses. So the symptoms of depression with a person with who the PLWD stands for a person living with dementia. You might see memory problems, which again, they may have memory problems because of their dementia. You might just see them get confused. And again, we see confusion with dementia as well. Social withdrawal we see with both. Loss of appetite and weight loss. Vague complaints of pain. I think that's the big clue there. Their inability to sleep. Are they irritable? And they may be irritable because they're not getting enough sleep. They may have delusions and hallucinations with both of them. And they may be dealing in grief and loss that they really have not dealt with. And so you might see those go hand in hand. And again, it's difficult, but if you're dealing with someone who has dementia and depression, you want to be calm in their presence and show your concern. Make sure that you're talking in a supportive, comforted way. Identify with the emotions that they're expressing. Check in daily, just for a few minutes. It really shows that you care. Sometimes that loneliness will spark that depression. Maybe suggest that they speak with the social worker, the nurse, the doctor, the chaplain, or the or someone spiritual in other religions to get more help. Encourage attendance at activities and support groups that are being offered. The thing is, you need to know who this person is. If you're taking them to activities they don't like, that's not part of who they are as a person, then we're going to have a problem. And so that's why I encourage anybody who is as a caregiver, if you eventually have to place someone in a community setting, give as much information about that person to the team as you can, because they can support them better if they know more about them. It's called their personhood. And then realize that depression, like anxiety, can change the chemistry of the brain, and that in itself will affect their cognition, just like dementia. So next is delirium, and that's a sudden change in mental function. So that's the difference between depression, dementia, and delirium. Delirium is sudden. There's changes in thinking, in concentration, and behaviors. And there's 3 different types. There's hypoactive delirium. Well, they'll kind of just sit and don't want to move. And it'll kind of look like they're depressed, but they don't want to move. But it occurs suddenly. Or hyperactive delirium, where they're bouncing all over the place. Or you might see periods of both, where they're having, and that's called mixed delirium, where they're having both of those. That's why we look at this and we say sometimes someone only has dementia, sometimes only depression, and sometimes only delirium. But you have to know where these cross over. So the clue for this is that it's sudden. The onset is typically sudden. And usually that delirium is just part of their dementia, or it could be part of their depression, or it could be maybe a urinary tract infection. It could be an upper respiratory infection, or those things that are changeable because they're medical and they're not changes in the pathology of the brain. So this is a good slide if you want to take a picture on your phone, and I can go back to it if you don't have enough time. But this gives the onset and the course of dementia, delirium, and depression. Dementia is slow and insidious. Delirium is onset, and depression is recent, with mood persisting for at least 2 weeks. That's the diagnosis for major depressive disorder. We've all been depressed. We're sad for a few days, but major depressive disorder is 2 weeks. And it can last obviously longer than that. The course symptoms are progressive for dementia. Delirium, they're short and fluctuating. Oftentimes they will get worse at night or when they wake up. And it's usually reversible with treatment of the underlying condition, such as urinary tract infection or something else that's going on. And depression, it's typically worse in the morning. And again, it's usually reversible with treatment. Their mood for dementia, and this is another one you can take a picture of. Their mood is depression may present in early dementia. And the reason it may show its face in early dementia is because in early dementia, people are aware that there's changes. They can't really put their finger on it, but they know there's changes, which is oftentimes why they isolate, because socially, they may not feel they can converse in an appropriate way anymore. Oftentimes in early dementia, that's true, and sometimes they still can. They know the social cues in early dementia. If someone said to me and I had dementia, "Hi, Chris, how you doing today?" I would say, "Oh, I'm fine," because that's one of the social cues that we get when someone asks us how we are. But if you ask me, "Do you know where the nearest Portillo's is?" I may not be able to tell you that. So again, that's when they start to isolate, and isolation leads to depression. Delirium, we're going to see fluctuating emotions. You might see anger, tearful outbursts, fear. They're kind of all over the place with their emotions. And with depression, they're going to see lack of interest in anything that's usual. And again, they may eat just to eat, or they won't eat at all. And then their attention. In dementia, it's generally normal. In delirium, it fluctuates. Again, they're all over the place. They have difficulty following a conversation. They have difficulty carrying on a conversation. And in depression, you might see that their attention may be impaired. They might just be focusing on one thing. It may look like they're needlessly staring. So that's what we see there. So again, I can come back to these slides. And then thinking, difficulty with word finding, and abstract thoughts, disorganized and disordered fragment with delirium, and then depression. Intact themes of helplessness and hopelessness are present with depression. And then our perception. And in dementia, you're going to see misperceptions, usually absent, and they can be present in Lewy body dementia. And delirium, they're distorted. You'll see illusions, hallucinations, delusions, and difficulty distinguishing between reality and misperceptions. And then depression, their perceptions usually intact, but if they have severe depression, you might see that they start to have delusions, or you might see that they have hallucinations. There's also something called transfer trauma that I want you to be aware of as caregivers. And that is when a person with dementia moves from one place to another. If they stayed in one place for one night and they get transferred, depending on where they are in their dementia, usually it's early to middle stage dementia, they're going to have the early part of middle dementia, they're going to have what's called transfer trauma. And that is stress a person with dementia may experience when changing from one living environment to another. So take, for example, your family member, and they have to go to the emergency room. And they decide that that person needs to be in in ICU. So they transfer them to ICU. So now they've been transferred from your home, they have spent the day in the ER, and now they're going to ICU. They're at risk for transfer trauma. Then they get sent to a floor, and they spend some time in that room for a couple of days. And now they're moving to a rehab center. They may experience transfer trauma. And then they get discharged to home. And again, they may experience transfer trauma. These symptoms can be unusual for them, and it could be misrepresented as depression. And it could be because of the change in environment, they don't know everybody, and they need to build that trust again. Sometimes they'll do some bizarre things with transfer trauma. My mother had that when we moved her from independent living to assisted living, and she was going up and kissing everybody. And that was totally out of character for her. We talked through it with the team, and I came, because I worked very close, I came 3 times a day. And when I came and visited with her, we would walk around and I would introduce her to people. And within about 2 weeks, she became very familiar with everybody, started to trust people, and that behavior went away. So, just be aware of that. If your loved one has dementia and they're moving from one place to another, you might see a change in their disposition. There is some grief and loss and bereavement with dementia because of that loss of independence. And then after that diagnosis, you have that anticipatory grief, or it might be because of the loss of a spouse or a family member. So again, think about what you would do if you see the signs and symptoms of depression and it's grief related. You may want to get involved in some grief counseling. It may not be that you need it as much as that person with dementia may need it, but you may need some cueing on how to handle that. And maybe if it's in early dementia, they may be able to vent and experience the bereavement group by with them there. So the screening and assessment, this is more clinical, so I'm not going to get into this. Just know that there's different screening tools for different things that we talked about today. Our healthcare professionals don't take this lightly. We don't like to diagnose people. Doctors are the diagnosticians. They don't like to diagnose things without an assessment of sorts. So there are different tools. And again, if you want to take a picture of this, let me know and I'll go back and follow it.